Thanks very much. Yeah, thanks very much, Dr. Hadari, for inviting me here to speak today at the network meeting, and it's lovely to meet all of you today. So I'll just pull up my slides. Okay, are you able to see the slides?
Yes.
Okay. Perfect. So yeah, as mentioned, this is our title for this presentation is Exploring Gender Inclusive Design and Digital Health Tools, and it's a case study of smoking cessation conversational agents. Just starting with disclosures. So this is academic work that's been funded by GEH Women Mind, which is a philanthropic activity that is meant to improve the science around women's mental health and addiction, and also promote women in science. So I'm very grateful for their support. And the other one is, again, a non-for-profit AMS Healthcare, which are looking, as we have more and more digital tools and more artificial intelligence, how do we make sure that compassion and other human traits are not lost in translation. So just start with the background, and I think for this audience, there's no need to provide too much information. I'm sure you're very all aware that historically biomedical research was conducted predominantly on male samples. And as a result, the research evidence and also clinical practice guidelines were male-centered. And this could lead to inequality in health outcomes between the sexes. And I think a very, an example that's very near to my heart, because I'm a physician that works in addictions, both smoking cessation, tobacco addiction, and other addictions. We know that for smoking cessation, we have a very gender-neutral approach, sex and gender-neutral approach, I should say, to smoking cessation. And we know that women fare less well compared to men, meaning that we consistently see also in our clinic that women have greater challenges in quitting smoking. And this is partly related to sex and gender influences on tobacco smoking and the fact that our treatment is not tailored. So the main question that we wanted to do in this case study is, we know that now there are more and more digital health tools that are coming into the market. And I think within the next couple of years, there's going to be a tsunami of digital health tools entering the health system. And what we wanted to look into is, how are these emerging, these new digital health tools? How are they faring? Are they maintaining that traditional sort of biomedical approach, which is more male-centered, not as much consideration giving to sex and gender issues? Or perhaps, we have an opportunity here to promote gender equality in health outcomes. But what this means is that, we need to have a deliberate design, methodology and leadership, which we kind of termed this gender inclusivity. So the aims of our case study was to, evaluate the gender inclusivity of smoking cessation conversational agents for cisgender women. Now I put cisgender in parentheses because we don't have that level of resolution for women, for gender diverse groups. It's we still are pretty early in the course of developing these agents. So it could be just women at this point, cisgender women. So what we wanted to do is, look into smoking cessation conversational agents. And I think, at this day with GPT-4, I think that, most people are quite aware of what conversational agents are. We put in text in a computer, in a smartphone, and then we get a response. And this could potentially mimic a smoking cessation healthcare provider, a counselor, encouraging me to, use different medications or helping me with acquiring behavioral skills. So looking into those new technologies that help people quit smoking through text-based conversations. So we wanted to, examined these smoking cessation conversational agents, looking into their methodology, leadership, design, through a gender lens. And in addition to looking into those studies, we wanted to get input from a multidisciplinary panel regarding the findings of the case study and come to an understanding, all of us together, around the key challenges and the opportunities for gender inclusive design. So this was our panel. Our panel members, we had quite a lot of folks from Canada, but also some from the US and from Europe. And largely speaking, our panel members were either scientists who are doing a lot of work in addictions. We had scientists that are doing work in sex and gender health, and we had scientists that were data scientists, software developers. So those were largely the three groups of researchers that we have. All of them are involved in academia. So yeah, we wanted to look into smoking cessation conversational agents. And in 2023, just last summer, this systematic review was published in the Living Journal for nicotine and tobacco research. And it identified 11 published smoking cessation conversational agents. And we examined those 11 studies. There were actually 13, but there were only 11 unique conversational agents. So some were a bit of an earlier version and some were more mature version, and some were examined with with different groups, but they were still the same conversational agent. So we looked into those 11 studies that were identified in the literature. We also corresponded with authors to get additional information. So what are some of the things that we looked at in the studies of conversational agents? So we looked into the methodology, who were the participants in the samples used to test the conversational agents, and specifically we wanted to see the representation across sex and gender, and also examining intersectionality, whether this was accounted for. We wanted to see whether there was a sex or gender-based analysis conducted, and specifically to determine two things. The first was the effectiveness, right? Are the smoking cessation conversational agents effective, both for men and women who use the tool? And we also wanted to look into the acceptability, which is another word for the user experience, I would say. So, what do people think about this conversational agents? And do women and men have different views, different takes on what they like, what they don't like? And of course, when you develop digital health tools, this could be really important. We also looked into the leadership, specifically the gender parity in the research teams. And we also looked into something that I think, more and more of us are using these days, which is co-design methods, and looking to see whether the conversational agent was developed with input from users. So here are, the results of this, case study. So with regard to sex and gender representation, we saw that in studies that came from Western countries, both US and Europe, we had females that were overrepresented among the participants, more, females than males. One study was quite a large one, did not even collect information on sex, which is a bit of a missed opportunity there. And then, in studies that came from Asian countries, males and females were representative of the population of smokers. So they had more males than females, because that's sort of, what the smoker population is. And of course, in Western countries, we know that more males than females smoke, more men than women smoke, but the ratio is, about 1 to 1.5. And in Asian countries, it's about 3 to 1. And we had two studies, interestingly, that had only males or almost only males included, both from, developing countries, Cambodia and Vietnam. With regard to, demographics and intersecting factors, so there was relatively little information that was given or collected. We know that we didn't, only two studies, for example, reported on education levels or employment status. Some studies reported on ethnicity, particularly in countries that have multiple ethnic groups. This could be like US, for example. With regard to a sex and gender-based analysis, right? So one of the main things we wanted to see whether this new digital health tool, conversational agent, whether there is a different effectiveness for men and women. And, this could be, of course, the result of a sex and gender-based analysis of the study results. And what we learned is that only 5 out of the 11 studies reported such an analysis. 3 out of the 11 studies explicitly analyzed and reported outcomes by sex. And by the way, they did not find a difference. And 2 of the studies, as I mentioned, were male only. Therefore, they reported the results by sex. With regard to the user experience or the acceptability, I think here was even a lower number of studies that reported. Most of the studies did not report, only 2 reported. And those were the male only studies. And one of the things, I kind of put a quotation here, a quote that, for example, some participants, and this is in the study of conversational agents, some participants mentioned that they would like to see a more self-paced interaction, for example, not being pushed by the agent to set a quit date. Now, we don't know who said this, was it a man, was it a woman? And we can sort of, suspect that this was, said by a woman, because we do know there's quite a lot of literature to support gender differences in smoking and smoking cessation behaviors. And we know that women have a greater, find it harder to set a quit date than men. And therefore, that's one of the reasons that it's harder for them to quit. So again, this is another missed opportunity to, when we use the user experience, we don't really get, we don't really know whether it's, this is said by a woman or by a man. Yeah, moving forward, the other item that we looked into would be the, gender parity in the leadership of the research teams. So as you can see, there's quite a homogeneous group of last authors with regard to gender. So, most of them were men. But this is sort of changing. I think the trend is changing towards when you look at the first author, the younger researchers are coming into this area. So we do see that there is a greater representation of women there, but still it's about 1/3 to 2/3. So still not, we don't have parity there. We also wanted to see whether the conversational agents were developed in a participatory design or co-design methods. And again, we found that the majority were not developed with input from users. Okay, so yeah, quickly, sort of summarizing some of the results of the case study. So most of the smoking cessation conversational agent largely developed in a sex and gender neutral approach. And we also know that they were discordant with the SAGR guidelines. We know that many of them did not use this, sex and gender-based analysis, both for effectiveness or for acceptability. We also saw that there was, lack of gender parity in the leadership of the teams, which could potentially explain why sex and gender-based analysis was not conducted. Limited use of co-design methods. And just as another note here that we communicated with the authors, and many of the authors reported that it was sort of the reason that they did not conduct a sex and gender-based analysis was because the conversational agents are just, very early levels, very early development stages. Therefore, they did not think that it was needed. It had very small samples. It was a pilot study. Therefore, they did not include that. Yes, I'm getting just to the last couple of slides here with regard to some of our panel discussions. So we had both a survey with, sharing the results and surveying the panel members, and also having a synchronous discussion to kind of, identify what are those key challenges that we can for gender inclusivity, and also what are some of the opportunities that might be might be helpful in the future to change these things.
This flight 348 to London Heathrow is ready for boarding at gate C59. Please have your boarding card available for inspection. Thank you.
I think someone is at the airport. Yeah, okay. Okay, so yeah, just quickly, just the last couple of slides before we open it up for questions, discussions. So yeah, the key challenges. So I think, one big thing that that struck us was perhaps the lack of knowledge, right? So a lot of the times we saw conflation of sex and gender. Perhaps people are not sure how to conduct a sex and gender-based analysis. So that was kind of, a big topic. Another thing is sort of, we have this paradigm of gender blind tradition, that's kind of the existing norm. How do we move forward from that? And we also noticed that, perhaps people are conducting a sex and gender-based analysis, but they're not reporting on it because, wasn't significant, for example. Another thing is, if we have a pilot study, if we have a very, small number of participants in the sample, perhaps a sex and gender-based analysis is not feasible due to the limited power of the sample. Another topic that came up is really the lack of regulation, both by funders and journals. And, one of our panel members mentioned, all NIH-funded work requires that sex and gender is considered in the design, but the policy is not always adhered to. So potentially, there's a great, research coming in, very strong, scientific background and team. And then they kind of, not, there isn't really a lot of focus on consideration for sex and gender, but it's sort of, because the funder feels strongly about this research, then it's funded even though they're not including sex and gender. Yeah, we talked about lack of gender parity, potentially because less women are involved in this work. There's, less of an impetus to conduct a sex and gender-based analysis. And, the social accountability also came up as, a lot of these, chatbots and digital health tools are, sort of collaborations between academic and for-profit organizations, venture capital. Maybe this means that they have, less interest in social issues, and especially gender, gender health. Equality perhaps is not at the top priority. So what are some of the opportunities that we can see, ahead? So I think, kind of mirroring what we said about the challenges is, really important to increase knowledge. Developers have appropriate training in sex and gender-based analysis, trying to incorporate sex and gender right from the initial sort of concept, planning, design. So really taking that into consideration. I think a huge part of the discussion was, we have such an opportunity with digital health tools to personalize, precision medicine, that's kind of a buzzword. So if we know ahead of time that some groups have, health disparities, this really calls for us to tailor the tool for those groups that have health disparities. This could be ethnic minorities, women, with low income, and other groups. It was done really nicely for the two studies that had men. One was for men with HIV, I think, in Cambodia, and the other one was, men in Vietnam. So it was really nicely done. The sex and gender kind of was really put nicely into those. Unfortunately, not for women, but it was done really nicely there. Another point is, we kind of have a lot of, accumulating knowledge, sex and gender health, sex and gender science. So when we are developing a tool for smoking cessation, we have, mountains and mountains of evidence of the sex and gender differences. So why not use some of that existing knowledge when we build the new digital health tools, and potentially, either consulting the literature or having a social scientist to just support that work. Yeah, and just calling for, consulting users, co-design, diverse samples, just getting more input from more folks around, around the specific tool. How does it work for you? What are your thoughts? What could make it better? Just to make sure that it could, answer for a need for these groups. Yeah, so I think this is where I'll stop sharing. This is the end of the end of the presentation.
Great. Thank you so much, Osnat. I'll stop the recording and then we can open up for